Hello, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Hope you guys are having a great week and a great Ramadan. Ramadan Mubarak. My name is Abdelrafour Houdane. Some of you guys may know me from before, some of you may not. I'm an intern from Al-Faisal University. I'm from the 10th batch, and I'm very happy to present today the physiology of the female reproductive system. Now, here's a quick table of contents. We're going to start with a quick introduction just to get the ball rolling. Then we're going to dive into sex differentiation, puberty, the female reproductive system in general. Then we're going to dive into the individual structures like the ovaries, the fallopian tubes, the uterus and the cervix, the vagina, external genitalia, and wrap up with the female sex act. So the gonads are the general term for sex organs, organs responsible for reproduction, and they contain special sex cells called the gametes. Now, in males, we have testicles. These are the male gonads, and the female equivalent is the ovaries. Now, the female reproductive system is composed of two main parts. You have the internal genital tract and an external genital tract. And it's important for us to have that distinction in mind, just because the embryology is very different. And that ties into the pathology later down the line. Now, the internal organs in the female reproductive system include the uterus, the fallopian tubes, and the upper part of the vagina. And externally, we have the distal or the lower part of the vagina, the vulva, the clitoris, and the labia, both the labia majora and the labia minora. Now, this section is very kind of low-key high yield, not necessarily for Al-Faisal, but more so for like Step 1 and Step 2 and for all those board exams later down the line, because they love to ask this and because it ties in really well with a lot of pathology. Now, the whole topic of sex differentiation is how does that developing embryo become a male or a female? Now, one important note to keep in mind is that the default template is female. In fact, it is the introduction of that SRY gene on that Y chromosome that kind of messes stuff up, and then you end up with a dude or a guy. But in the absence of that SRY gene, the default template is always going to be female. Now, when you don't have an SRY gene, those undifferentiated gonads will be like I, and they will develop into ovaries. Now, there are two important structures to know. That's going to be that you have something called the Mullerian duct, also known as the paramesonephric duct. This Mullerian duct will eventually become all the structures of the internal tract. So the uterus, the fallopian tube, and that proximal part of the vagina. Those gonads, the moment they become ovaries, they begin to secrete estrogen, and estrogen is responsible for the development of the external genitalia. So the internal genitalia are formed due to this Mullerian or paramesonephric duct, and the external genitalia is formed under the influence of estrogen being produced by the ovaries. Now, why does the absence of the SRY gene lead to that female template? That's because the main role of SRY gene is to produce something called the anti-Mullerian hormone. So if the patient is 46XX and does not have a Y chromosome, it does not have that SRY gene, therefore no anti-Mullerian hormone is produced. Now, this diagram is from first aid. It kind of gives you a good idea of the sex differentiation both in males and females. And we'll focus, for the sake of this lecture, on that female side of the diagram. You start with undifferentiated gonads. We said, again, this is an XX chromosome, so there's no Y chromosome, there's no SRY, so the default template is female. And you basically begin to form ovaries. These ovaries will do two stuff. They will produce estrogen, and the absence of that anti-Mullerian hormone will lead to the normal development of the paramesonephric ducts. The estrogen will go and lead to the formation of the external female genitalia, and the paramesonephric duct will form the internal male genitalia. Now, you will notice in the slide, there's a distinction between the primary and secondary sexual characteristics. Now, the main difference between the two is time. Primary sexual characteristics are the things that you are born with. It's going to be your uterus, it's going to be your vagina, it's going to be your clitoris. The secondary sexual characteristics they arise during puberty. These are going to be the breast development in women and the presence of pubic and axillary hair, and also the presence of menorrhea or menstruation or periods. This diagram is from the slides. It looks a bit messy, but again, it's just really repeating the same thing that we've been talking about. Here on the side, you have the formation of the internal genital tract. And you can see you don't have that SRY gene. That gonadal cortex becomes the ovary. The lack of testosterone being produced by the ovaries in the beginning will lead to degeneration of that Wolffian duct. And that's important because you do not really want that Wolffian duct. The Wolffian duct is responsible for the male genitalia and the male internal genitalia. So that will ensure you only have the parts that you need. Finally, the lack of anti-Müllerian hormone will lead to the Müllerian duct becoming the internal tract. So this slide from the lecture is just a repeat of what we have spoken about before. Here now, looking towards the external genitalia, you can see that how you have that genital tubercle. It's green on the side, on the image on the right. That genital tubercle will eventually become the clitoris. Now, I want you to kind of think of the clitoris being the equivalent of the glans penis in males. They are very, very similar. They both are made up of erectile tissue, and they both get erect during sex. Then you have those urethral folds and grooves. These will eventually form the labia minora. They will form the opening of the vagina as well as the urethra. And finally, you have that labioscrotal swellings. These will eventually become your labia majora. So this checkpoint is if anyone does not has any questions. I don't think there is, so I'll just move on. So let's present you a little cheeky case to see why is this relevant. I know in first year, you take a lot of material and kind of look, you wonder like, why? What's the point? The truth is, first year, a lot of it builds that foundation for later on. You gotta know the normal processes to better appreciate the pathology. So in this case, you have an 18-year-old lady. She's presenting to your clinic. She's absolutely fine. However, she's complaining that she never got her period. She's 18 and she never gotten a period her whole life. Now, you do your physical examination. She has normal breast development for her age. She has normal external genitalia. She has her pubic hair and axillary hair. But the only thing is she does not have a period. You decide to do a pelvic ultrasound to see, is everything okay in there? Is uterus okay? Is there a problem? And in your ultrasound, you come to a very interesting finding. You find nothing. No uterus, no fallopian tubes, and a blind ending vaginal pouch. This is a patient with a condition known as Müllerian agenesis, and it's a defect in that paromesonephric duct. If for whatever reason, there is a congenital anomaly in the Müllerian duct, all those internal genitalia will never present. However, you have those functioning ovaries. They are producing estrogen, therefore they will have a normal external female genitalia. And obviously, this is not from the slides, it's from later on. I just want to tie it in now just to give you guys a better appreciation of why this topic is important. Now, where does all that embryonic development stuff come in? All that oogonia and oocytes and all that stuff. This is the same side that we are very familiar. It's the same thing again, just with the addition of that extra kind of like embryonic stuff. So as you can see, when the ovary is formed due to the absence of the SRY gene, you have the formation of the ovary. There you will have the oogonia start becoming formed. They will turn into primary oocytes. They will combine with granulosa cells and become primordial follicles, etc., etc. In terms of just like timelines, at around 7 to 12 weeks, you have the first like meiosis of the oogonia. But they, as you guys know, they arrest at that first meiotic prophase. During that stage, you also have ovarian organogenesis. The ovaries are becoming more developed, the structure is becoming more refined. And you have the formations of those primordial follicles when the oocyte begins to vibe around with the granulosa cells. Eventually, at around 11 to 12 weeks, you have the formation of the fallopian tubes. Dr. Abdelrafour calls them the oviducts for some reason, as well as the uterus, the cervix, the external genitalia, and the vagina. And around 20 to 25 weeks, you have the formations of your first primary follicles in the ovary. So that kind of wraps up sex differentiation. Now we're going to move on to puberty. Now, puberty comes at a very interesting time. It's usually kind of chaotic, both like physically and psychologically, and it's just a mess. But in terms of defining what puberty really is, it's when your secondary sexual characteristics begin to kick in. You are now becoming reproductively mature and ready for reproduction. So before we dive in, there are 3 terms that you're going to be hearing a lot now. And you're going to hear a lot about them next year when you do Repro again. And you're going to hear about it a lot in OB-GYN. and you're going to hear a lot about it in internship because it's a very, very important topic. And these are adrenarche, thalarche, and menarche. Now, adrenarche is the formation of armpit and pubic hair. It's the onset of armpit and pubic hair. As you guys probably remember, as kids, we don't really tend to have armpit and pubic hair. Usually that's a sign of hitting puberty. Next up, we have something called thalarche, and this is the onset of breast development. Finally, you have menarche, which is the onset of menstruation. It is that first period. Now, you may have noticed there was this particular order in how I organize it. That's because menarche comes last. Menarche is preceded by adrenarche and thalarche. You have the onset of pubic hair, you have the onset of breast development, and then a bit later down the line, you will have your first period. Now, this onset of puberty is very linked to the amount of adipose tissue you have. And I don't know if you guys know anyone from your personal family or friends, but a lot of athletic girls or girls with very low body fats tend to hit puberty a bit later. But why is that? What's the link between adipose tissue and puberty? Well, it boils down to two things, aromatase and leptin, and they're both found in adipose tissue. The higher aromatase you have, or the higher leptin you have, the earlier the onset of puberty is, and the opposite is true. But why is that? So aromatase does one thing. It converts those circulating androgens into estrogens. And we spoke about earlier about how estrogens are very important in breast development. So that increase in estrogen due to high levels of aromatase found in adipose cells leads to early puberty because now you start having the breast development and everything kind of like cascades from there. Another important component, another ingredient in the mix is leptin. Now, leptin works on hypothalamic maturation. Without going into too much detail on the physiology, the hypothalamus plays a very important role in kick-starting the menstrual cycle, the pulsatile GnRH secretions, and leptin works on that. So a higher leptin or a higher aromatase, both linked to higher adipose tissue, will lead to an earlier onset of puberty, and the opposite is true. So how do we determine how far someone is in the pubertal development? Are they at the start? Are they towards the end? Are they in the middle? Sorry. And to answer this question, we have a system called the Tanner stage system. Now, the Tanner stage system looks at three things: the genitalia, the pubic hair, and breasts. And it looks at them independently. And together you have the different Tanner stages. And the best way to really understand this is by looking at the diagram and understanding and visualizing those changes. So before I dive in, I just want you to always remember the earliest detectable secondary sexual characteristic is that breast bud development. And we're going to see this when we go into the Tanner stages. So this is another diagram from first aid, and it goes over the Tanner staging system for females. And it goes from stage 1 all the way down to stage 5. So let's go with it one by one. Stage 1 is pre-pubertal. This is before puberty kicks in. Here you could notice that there is no sexual hair. The chest is very, very flat, and there is maybe just like a raised nipple. On stage 2, however, this is going to be your adrenarche, right? This is going to be the onset of pubic and axillary hair. In females, also, this is going to be the breast bud formation, that thalarche, right? That mound begins to form, and it's the earliest secondary sexual characteristic that develops. Moving on, you have now thickening of that pubic hair. It's getting thicker, it's getting coarser, but it's still on the pubic region. It did not move to the thigh. The breasts slowly begin to enlarge, where again, at this stage, the areolas are still flat. At around stage 4, again, you have even thicker hair entirely across the pubis. Okay, it's becoming a bit more bushy. The breast is enlarging, the areola now is beginning to rise up, and we call this a mound on mound because you have the mound of the areola on top of the mound that is the breast. And finally, on stage 5, you basically have hair that has now reached across into the medial thigh. Shaving becomes a bit more of a hassle. The adult breast has gotten even larger and has developed that characteristic adult breast contour, and also the areola flattens, and now you have the normal adult. And that's usually around over the age of 15. So that kind of wraps up the that kind of wraps up puberty. Moving on to the female reproductive system, I think it's always important to understand structure. You must understand function and vice versa. If you know the structure, you will know the function. And if you know the function, it will better help you appreciate the structure. So the main function of the female reproductive system, the main goal of the female reproductive system is to supply the ova for the sperm to fertilize and then serve as this location, this perfect environment for the embryo to implant, to grow and mature and eventually leave as an independent little baby. Reproductive age is defined as from menarche all the way down to menopause. This is the moment in time where a person is able to get pregnant. They are reproductively mature, maybe not mentally mature, but at least from a reproductive side of things, they are able to conceive and are able to have a viable pregnancy. And that kind of like is related to two things: the ovarian cycle, which you guys, I'm sure, have taken this before, but the whole goal of the ovarian cycle is to prepare the ovum for fertilization, and the uterine cycle prepares the uterus for implantation, making the endometrium very nice and soft and thick and just perfect for implantation. Here's another example again of the female reproductive system. As you can see, as we said previously, you have an internal genitalia composed of like your uterus, your fallopian tubes, your cervix, and your upper vagina. Then you have the external genitalia with the clitoris, the labia majoris and minoris, and the opening for the urethra and the vagina. So let's go through each like functional unit in one by one. We start with the ovaries. As we said previously, the ovaries are the female gonads. They contain a lot of those, gametes, those ova. The ovaries job description, the main goal of the ovaries is really to do two things. One of them, obviously, is oogenesis, to produce these kind of like ovum ready for fertilization. And also, and a lot of people tend to forget this, they have a very important endocrine function, and that is secreting sex steroids. Now, sex steroids, what I mean by that is going to be estrogen and progesterone. The ovaries functionally have three zones. They have a cortex, they have a medulla, and they have a hilum. And this is an example or a diagram of the ovaries. You can see you have that cortex on the outside, and then you have the kind of like space in the middle full of kind of like stuff. That's the medulla. And then the hilum containing those blood vessels and lymphatics that basically provide nutrients to the ovaries, because obviously they need stuff to live. So let's go through one like piece by piece. We start with the cortex. This is lined by germinal epithelium. It contains a lot of follicles with a lot of these little oocytes inside. And it's also a site of steroid synthesis. This cortex is very important for the production of both estrogen and progesterone by the corpus luteum when it degenerates. Also kind of like the clinical role, and you will take this when you do EndoRepro 2, the cortex is important because it could be a site of cancers, could be a site of these, they call them epithelial ovarian cancers. Then you have the medulla. The medulla is just going to be filled with stromal connective tissue. It's important for the survival and the function of the rest of the ovary. Then you have the hilum, which I said previously, brings those blood vessels, bring those lymphatics into the ovary. And also their clinical kind of like role is they could be a site of ovarian torsion. If you thought testicular torsion was the only thing that exists, well, I have news to break to you, because ovarian torsion is a thing, and it's kind of really nasty and very, very icky. So again, just to like recap, the main role of the ovary is oogenesis, as well as secreting sex steroids, which are going to be your estrogen and progesterone. And these estrogen and progesterone have both a local effect and a systemic effect. Now, when we say something, when we say a hormone is acting locally, you guys know we use the term paracrine. So the paracrine effects of the ovaries is that it's important for the development of ova. It supports the development of those granulosa and theca cells, and their systemic effects or their endocrine effects is important because they go and impact the breast. They lead to breast enlargement and breast engorgement. They go to the uterus and they have a role there, and they go to the bone and they cause the bone to get nice and strong and thick. And if you guys know me, you know I'm pretty obsessed with bones. I want to go into ortho, so I can tell you the reason why a lot of older females after menopause, they come with fractures, is because menopause is all about that drop in estrogen. The bones get weak, then they slip and they break a hip, and that's like a pretty big boo-boo diddy. Now, moving on to now the ovaries hormonal function, just a bit more in detail. Again, the ovaries hormonal function plays a role in providing nutrients to the oocyte, gives it nice stuff to get big and strong. It signals the oocyte to leave and just like you rupture out of the ovary into the fallopian tubes for ovulation. for fertilization. We call this process ovulation. It also goes and prepares the vagina and the fallopian tubes to aid in fertilization, assist the sperm in going up so they're basically acting like wingmen. Okay. Also prepares the uterus to line it and optimize it for implantation if the ovum is fertilized. And finally, it has a very important role in keeping that implanted fetus alive until the placenta can take over and start producing a lot of those hormones responsible to maintain that viable pregnancy. Now, moving on to the fallopian tubes. I don't know why it's called the oviduct. I never knew it was called an oviduct before, but I guess you always learn something new. There is two muscular tubes that serve as highways for the eggs to get fertilized. I spelled it wrong, but now it just sounds more American. Oopsies. So this is kind of like a little diagram of the fallopian tubes. One very important thing, when I came into medicine, I always thought the fallopian tube was connected to the ovary. Turns out they don't. There's still a bit of space, but the distal portion of that fallopian tube has these like finger-like projections. They call them fimbriae. They kind of just like the ruptured ovum. It's also important to note that the epithelium is lined. It's simple epithelium with both ciliated and secretory cells. And I want you to kind of remember the ciliated part because I'm going to go back into it. But again, it's kind of like the same kind of concept where you have that little egg floating inside the fimbriae. You want to kind of like push it towards the uterus, and that's done in part with the help of those cilia. There are basically four parts to the fallopian tube. You start with that infundibulum with those finger-like projections. Then you have the ampulla, which is the widest part. Then you have the isthmus, which is the narrowest part. Then you have an intramural segment, which is inside the uterus technically. Now, there's a cute little red asterisk on the isthmus, and it's because it is very, very, very clinically relevant because it's the narrowest part, and therefore it is a potential site for ectopic pregnancy. So what can happen here is the fertilized egg could get stuck because it's the narrowest part, and it just says, you know what, I'm just going to start developing. Guess I'm just developing. So eventually that could lead to rupture of that fallopian tube, and the mother could die if not treated quickly. Now, the fallopian tube function is to capture that oocyte and transport it towards the uterus. It's also a site for sperm storage. Some of the early birds, the early sperms, get all the way up and they just decide to chill on the isthmus. So they kind of wait for the egg to come, and then it's like free season. Also, the fallopian tube produces secretions that cause something called capacitation and hyperactivation of sperm, which you guys probably have taken previously. But that's why we said that the epithelium of the fallopian tube contains those secretory cells. And these secretions also go and give nutrients to the eggs to keep them alive. It allows for the movement of the embryo into the uterus after fertilization. And also the job of the fallopian tube, because it takes time for that embryo to reach the uterus, it got to support the embryo and give it enough nutrients to be able to make it to that blastocyst stage, eventually heading to the uterus for finally implantation. Now, I said this before, what if it goes wrong? Because a lot of pathologies happen. We spoke about ectopic pregnancy, right? So let's say a mother, for example, had an infectious disease, or she had a surgery, or she had like an infection, and she developed scar tissue in the fallopian tube. That's a really bad thing because that scar tissue could cause that embryo to get stuck, and we have ectopic pregnancy, which we spoke about earlier. And again, very, very common question, very common board question, and you get pimped about this all the time when you do your OB/GYN rotations. It's what's the most common location for ectopic pregnancy? And the answer is the isthmus because it's the narrowest point. Now, imagine a disease where we have abnormal cilia. We said that the epithelium was ciliated. Now, there is a disease called primary ciliary dyskinesia, which is basically defined as having abnormal cilia. One of the complications of this disease is infertility because the egg is not easily transported to meet the ovum. That's a very important complication of primary ciliary dyskinesia, and it's linked with the functional structure of the fallopian tube. So again, what you're taking now may seem boring, but it's important. It plays an important role in understanding the stuff that you're going to take later on. So don't feel bad. Feel just a little bit bad. So we're done with the ovaries and we're done with the fallopian tubes. Now it's time to move on to the uterus and the cervix. Now, this is a diagram from first aid. You can see that this is the uterus. It's very thick. It has 3 layers. It has an outer perimetrium. Then you have a strong muscular layer called the myometrium. The uterus gotta be strong. It gotta be muscularly because I know that's not a real word, but I just made it up. It gotta be big and thick and strong because its job afterwards is to pump and just squeeze that baby out when it's ready, when the rent is when the rent is due. Finally, you have the inner layer, which is the endometrium. And again, the endometrium is heavily involved with a lot of that menstrual cycle. It changes a lot. It's a very dynamic structure. Here you can see the uterus basically has the uterine body, the main bulk of the uterus, and then you have that lower segment, also known as the cervix. Now, the endometrium is dynamic. It changes based on the hormones. During some stages of the menstrual cycle, it's going to be very thin. In other stages, it's going to be very, very thick, and it's going to be very glandular and perfect for implantation. Now, the uterus function it's obviously a site of implantation for the fetus. It's very thick and it has a very nutrient stroma, so it's perfect for that job. It keeps the embryo attached to the endometrium and prevents it from invading and just like invading into the abdomen. It provides the maternal side of the placenta, so it's important for fetal and maternal gas exchange. It grows and expands with the fetus. And finally, it is very strong and muscularly, so it can contract and yeet that baby out. The cervix function, it serves as a gate to the uterus, right? The cervix function changes based on the menstrual stage. So during that follicular stage, which is very estrogen dominant, right? Estrogen predominant, you want fertilization to happen, right? So the cervix will produce this very thin and watery and alkaline mucus, which is perfect. The sperm love that. It helps the sperm go up. It makes the sperm kind of like all hyped up. It's like a very motivating kind of like environment. In comparison to the luteal stage, which is progesterone predominant, where theoretically you could be pregnant, you don't want more sperm to go into it, so there the mucus becomes much more thick. It becomes much more slightly acidic, and the main job is to prevent the sperm from going all the way up. This is an image of the cervix. You can see the normal cervix is how it looks, and you'll notice how the color kind of changes. That's the transformation zone. This is important to the point where the type of epithelium changes, but it's also clinically important because it's the most common site for cervical cancer. So whenever we do a pap smear, I think you guys are a bit young for pap smear, but when you're 21, you're able to do a pap smear. You will take a small like smear from that region and you will look for any signs of malignancy. And it's one of the best ways that we can prevent endometrial and cervical cancer. And here's like, I know, I hate this, but this is a good example of that transformation point. The transition from a squamous epithelium, kind of epithelium that we see in the uterus, and that point of transition, that transformation, is noted down by that yellow star. So now moving on to the vagina. Now the vagina is both the site of intercourse as well as the birth canal, where the baby is eventually going to pass through unless the baby decides to take the different route of a C-section. Now the vagina is a very muscular tube has no glands. Now, you guys, I don't know if you've taken male reproductive science, but lubrication is very critical and very important for a pleasurable sex. Otherwise, humans and animals will not have sex if it's painful. Now, the big question is, if the muscular tube, if the vagina does not have glands, where does that lubrication come from? The answer, it comes from three sites. The cervical mucus that we said earlier does provide some lubrication. You have some transudates that come from the blood vessels of the vagina. And finally, the vestibular glands in the vulva, like the carapace gland, will secrete stuff that will make the vagina very moist and facilitate for penetration. Now, the vagina is innervated by the pudendal nerve. This pudendal nerve is going to be the reason why sex feels pleasurable, is the reason why orgasms occur during intercourse, is because it is very, very innervated by this pudendal nerve. Now, this location which has the highest amount of innervation is going to be the clitoris, which explains why that clitoris is the part of the female genital tract which feels the best during sex. Another important function of the vagina, or another important thing to note, is the role of estrogen in keeping the vagina wall healthy and maintaining that glycogen content. And that's very important because it ties in with a lot of changes that happen during menopause. And again, menopause it's basically associated with a decrease in estrogen. This decrease in estrogen means that the glycogen content of the vaginal wall decreases, as well as the proliferation decreases. So a lot of patients will present with vaginal atrophy. They will complain with very painful sex, even when they use lubrication. And one of the treatments that we do for these patients is we give them maybe a lubricating gel that contains a bit of topical estrogen, just to kind of like make the vagina a bit more proliferated and increase that glycogen content again. And again, this ties in some basics with the clinical relevance. Another important feature of the vagina is that it is acidic. The acidity of the vagina is important because it kind of it serves as a barrier for pathogenic microbes, stuff like Neisseria gonorrhea and chlamydia. This is going to be one of your barriers of entry, and that environment is caused by your local vaginal flora. Every vagina has its own normal bacterial population. It's only when that bacterial population is altered, for whatever reason, that you start having like pathology or having infections or vaginosis, etc. Now, finally, we're about to wrap up with the anatomy, the external genitalia. This is very, very simple. This image is from first aid, and you can see again, you have the vulva, okay, which contains the opening for the vagina, the opening for the urethra. You have the clitoris with the clitoral hood on top. Then you have the labia minora, and finally the outer labia majora. And it's the same thing here. And anteriorly, you also have the mons pubis, which is going to be that fat pad, that fleshy kind of pad anteriorly. And then you have again the two labias, the majora and the minora, the vestibule, and this is again the same anatomy of your vagina, of your vulva. Now, the vulva's function is important because it's the site of penetration. It is important for both sexual arousal and orgasm, which is critical for the survival of the human species. It also plays an important role in directing the flow of urine, and also kind of like allows the vagina to partially close when not used to prevent entry by external pathogens. And again, just to kind of tie everything together, the Female Sex Act kind of like takes everything into account. It is identical to the Male Sex Act in terms of the phases. You have the excitement phase, the plateau phase, the orgasm, and the resolution. And there's a lot of similarities and some minor differences, obviously, because you have different anatomy. So let's start with the excitement phase. During the excitement phase, this is both psychological and physical. And it's important because that explains why, like during sex, foreplay is important. There is an important component of psychological excitement that kickstarts everything. Furthermore, stimulation of the clitoris and the vulva will trigger a parasympathetic response, which is identical to how an erection in males happen during excitement. Excitement, whether it's psychological or physical, will lead to a parasympathetic response. In males, that's important because erection happens when there is a vasodilation and an inflow of blood. But that also is true for females because during the plateau phase, you have an inflow of blood into the vulva due to the parasympathetic response. This will lead to a variety of different phenomena. Number one, you have clitoris erection. The clitoris gets a bit larger, it gets a bit harder, firmer. The labia will begin to swell up as it begins to get engorged. The face will begin to get flushed, and also the breasts all begin to get engorged. Systemically, you also will have an increase in the heart rate, an increase in the blood pressure, increase in respiratory rates. Eventually, you reach the peak of the sex act, which is orgasm. This is now a shift from a parasympathetic response to a sympathetic response. There are rhythmic contraction of the pelvic muscles. However, important to note, unlike in males, there is no ejaculation. This is just, yeah. And finally, you have resolution, very similar to males. You have the systemic manifestations will decrease, the heart rate will go back to normal, the blood pressure will begin to decrease, and that pelvic congestion will begin to decrease also. And that basically concludes this talk. I don't know if we have any questions, if we have any participants, but I'll try. Oopsies. Okay, so let me see if I can open the chat so I can see the responses. Ah, okay, perfect. So, to the two people who are awesome enough to attend, what determines sexual differentiation and development of ovaries? Is it the presence of anti-Mullerian hormone? Is it the absence of anti-Mullerian hormone? Is it the lack of testosterone or the presence of estrogen? Ooh. So this is very good. We have two answers. We have a D and a B. Now, the correct answer is B. It is the absence of the anti-Müllerian hormone. Now, notice how the question asked for sexual differentiation. It did not ask for development of secondary sexual characteristics. Estrogen is important for developing the external genital tract. But this question wants to know more about what allows those gonads to become ovaries. And the answer to that is it's the absence of anti-Müllerian hormone. If we have anti-Müllerian hormone, usually found on the Y chromosome, we're going to have the breakdown or the destruction of the Müllerian duct. So you don't have the formation of the ovaries, and the internal genital tract is not formed. So if you have anti-Müllerian hormone, you basically will have testicles instead of ovaries. Next question, which of the following structures come from the paramesonephric duct? Is it the ureter? Is it the uterus? Is it the ovaries? Is it the labia majora, the labia minora, or all of the above? Yep, absolutely correct. The correct answer is the uterus, the labia majora, the labia minora, both come from the effects of estrogen on the external genital tract. The ureter comes from something else. Honestly, I don't know. I forgot. It's been a long while. And the ovaries come from the absence of the anti-Müllerian hormone. So thank you very much for listening. Hopefully this did not take too long. And if you have any questions, whether it's related to the topic, whether it's related to any topic from first year all the way down to internship, this is my Twitter account. You can just DM me there and I'll be more than happy to help or just send like a detailed answer or video to any question you guys may have. Thank you so much for listening and all the best in your exams.